Welcome to the deep dive. Today we're venturing into a really fascinating part of neurology.
We are indeed. We're looking at how our brains handle learned movements and how we recognize things around us.
Exactly. We're diving deep into apraxia and agnosia. So apraxia, that's kind of like a breakdown in knowing how to do something familiar, right? Even if you're physically able.
Precisely. And agnosia is more like a glitch in recognition, even when your senses, your vision or hearing are working fine.
Okay, so for this session, we're really going to unpack chapters 11 and 12 from our source material.
Right. Focusing first on limb apraxias, then moving into the different kinds of agnosia.
And these aren't just abstract concepts. They affect real people, and honestly, they tell us so much about how the brain is organized.
They really do, sometimes in very unexpected ways.
Absolutely. So our plan is to explore these thoroughly. We'll start with limb apraxias, define them, look at the types, what's going on underneath, how doctors test for them,
Yeah.
and their clinical impact, yeah. Then we'll pivot to agnosias, visual, auditory, tactile recognition, focusing on the mechanisms there too.
And hopefully you'll have some aha moments along the way as we see how these conditions reveal just how complex brain function is.
Definitely.
Okay, let's kick things off with limb apraxias. In simple terms, what are we talking about here?
Okay, so limb apraxia, at its heart, it's a neurological issue where someone can't correctly perform learned, skilled movements. We're mostly talking about the arm or hand here.
Learn skilled movements, like using a tool or waving goodbye.
Exactly, those kinds of things. And the really crucial point is this isn't because of a basic motor problem. It's not weakness or spasticity or bad coordination like you see in ataxia.
Right, not like they can't move the limb.
Precisely. It's not tremor or other involuntary movements either. It's really a cognitive thing, a problem with the brain's programming for that specific learned action.
So the program itself is corrupted somehow. That's a good way to put it. It leads to errors in, say, the timing or the spatial aspects of the movement, how you position your hand, the path it takes. Or sometimes the error is in the actual content of the action, doing the wrong thing entirely.
Like you know what you want to do, maybe brush your teeth, but the brain just can't send the right signals to make it happen smoothly.
Exactly that. And that's why distinguishing it is so key.
Yeah.
It's not a sensory deficit where you can't feel properly. It's not neglect where you're unaware of a limb.
Yeah.
And it's not just part of a bigger cognitive issue like severe dementia or not understanding instructions because of aphasia. It's a specific breakdown in executing learned motor plans.
That makes sense. It has to be quite specific. And you mentioned it's neurological. Is it common?
Actually, yes, it's surprisingly prevalent. Studies suggest something like 50 to 80% of people with a lesion in the left side of their brain, often from a stroke, might show signs of it initially.
Wow, that high.
Yeah, and it can stick around too. Maybe 40 to 50% still have it persistently.
And it's not just strokes, right? The source lists quite a few conditions.
Oh, definitely. Beyond stroke, you see it in MS, brain tumors, especially affecting the parietal lobe, which we'll get into.
Right.
Corticobasal syndrome, Alzheimer's disease.
Alzheimer's too. Interesting.
Yeah, and some types of primary progressive aphasia, Parkinson's, dementia with Lewy bodies, Huntington's, even CJD, and sometimes in schizophrenia. So it cuts across many different neurological illnesses.
That's a really wide range.
Yeah.
So what's the real-world impact for someone living with limb apraxia?
It can be pretty significant. Think about all the things we do every day that rely on learned hand and arm movements, getting dressed, making coffee, using cutlery.
Right. Basically everything.
Pretty much. So apraxia can really interfere with those activities of daily living, leading to needing more help from caregivers. It can also really hamper rehabilitation efforts after something like a stroke.
And I imagine communication could be affected too if gestures are impaired.
Exactly. If someone also has trouble speaking, gestures become really important, and apraxia can interfere with that as well.
It seems like something that would be noticed easily then. But the source says it's often underdiagnosed. Why is that?
Yeah, that's a key point. There are a few reasons. Sometimes, if a patient has weakness on one side, say right-sided weakness after a left hemisphere stroke,
Hemiparesis, right?
right, hemiparesis, that obvious weakness can kind of overshadow or mask the apraxia in the same limb. Also, if it's the non-dominant hand, the left hand for most people, a bit of clumsiness might just be dismissed.
Just seen as normal awkwardness.
Exactly. Another factor is awareness. Some patients, especially after certain types of strokes, might not be fully aware of their motor planning difficulties, which obviously makes diagnosis harder.
Okay.
But even beyond that, sometimes clinicians might just not be testing for it specifically, or they might not recognize the more subtle error types that signal apraxia.
It really requires specific attention then. Now, we're focusing today on limb apraxias, specifically arms and hands. Are there other kinds?
Oh, yes, definitely. Apraxia is a broader term. There's oculomotor apraxia, difficulty with voluntary eye movements, apraxia of gait trouble initiating walking, feet feeling stuck.
The magnetic gate.
That's the one. Then you have apraxias involving more visual spatial stuff, like ataxia problems with visually guided reaching, constructional apraxia, difficulty drawing or building, dressing apraxia.
Okay, quite a few.
And then there are others that fit the impaired learned skilled movement definition but affect different areas. Orobuccal facial apraxia, trouble with voluntary face and mouth movements on command, and apraxia of speech. That's a motor planning issue specifically affecting articulation.
Got it.
But yeah, for this deep dive, as the source material lays out, we're really zooming in on the 7 main limb apraxias affecting the upper extremities. These are kind of the classic examples. Okay, clear focus on arms and hands. Let's rewind a bit. How did our understanding of this evolve? I wasn't always clear what was happening, was it? Not at all. It developed over quite some time. You had early observations, like from Healings-Jackson in the mid-1800s, noticing patients who intended to move but couldn't, even without paralysis.
Interesting. So noticing the disconnect early on.
Right. Then later terms like asymbolia or parakinesia started hinting at this cognitive component. But the real breakthrough came with Hugo Carl Liepmann in the early 1900s. His work really laid the foundation.
Liepmann, what were his key insights?
He proposed this really influential 3-stage model for purposeful movement. First, retrieving what he called movement formulas, basically the brain's blueprint for the action stored in the left hemisphere.
Like the memory of the movement.
Kind of, yeah. Second, transferring these formulas to motor programs or innervatory patterns in what he called the left sensimotorium, think premotor areas, supplementary motor area, SMA.
Okay.
And third, sending that program to the primary motor cortex on the left side to control the right limb. He also figured out the corpus callosum's role, that bridge between hemispheres for controlling the left limb, needing the plan to cross over.
That's quite detailed for the early 1900s. Did he classify types of apraxia too?
He did. Based on where he thought the breakdown occurred in his model, he talked about ideational, ideokinetic, which later became mellokinetic and limb kinetic apraxia.
And have those classifications held up?
The terminologies has evolved and our understanding is more nuanced now, but his fundamental idea that skilled movement involves a cognitive planning process that's really stood the test of time. It was remarkably insightful.
Absolutely. So building on Liepmann, what's the modern view? How do we think this network operates now?
The contemporary model still emphasizes that critical link between the left parietal lobe acting as a sort of central hub and the motor areas in the frontal lobe. This network is key for executing learned skills, but also for learning new ones and translating that mental idea of an action into actual movement.
And those movement formulas Liepmann mentioned.
We now often call them praxicons, or visuokinesthetic motor engrams, essentially stored representations that blend visual information and the sense of movement kinesthetics. And these can be triggered by different things, seeing something, hearing a command, even touching an object.
And where exactly is this parietal hub?
The inferior parietal lobule, or IPL, in the left hemisphere is considered really critical. Research shows neurons there are active not just when we move our hands, but also when we process object shapes and sizes, and when we actually use tools.
Oh, it integrates object information with movement.
Exactly. Functional imaging studies back this up, more activity there when we recognize tool use actions, what we call transitive actions. And different parts of the IPL seem to connect more strongly to either motor or sensory areas, suggesting some specialization within that hub.
You mentioned tool use. Is understanding the tool's function part of this network too?
Yes, absolutely. That's where action semantics comes in. It's the knowledge of what a tool does, how it's used, and which tool is right for the job. Like knowing a key is for turning, not stirring. It's the meaning behind the action involving objects.
Okay, so we have the movement formulas in the parietal lobe and the action semantics. How does that plan actually get executed? Where do the motor programs come in?
That's primarily the job of the premotor regions in the frontal lobe, especially the supplementary motor area, the SMA. The SMA takes those parietal movement formulas and translates them into detailed, specific motor programs.
It refines the plan.
Exactly. It's also crucial for sequencing the steps within an action and for coordinating both hands together. From the SMA, the program goes to the primary motor cortex, which then directly signals the muscles in the opposite limb, the contralateral limb.
And for the same side limb, the ipsilateral one.
The commands are thought to cross over through the corpus callosum to the other hemisphere's premotor cortex before heading to that side's primary motor cortex. It's a complex coordination.
It definitely sounds like it. But the source mentioned this left parietal frontal pathway isn't the only thing involved.
That's right. It's central, but not the whole picture. The prefrontal cortex, for example, involved in higher-level planning, also plays a role in sequencing complex actions. Okay. And interestingly, both parietal lobes seem involved in integrating visual information for limb movements, and maybe even in non-purposeful movements, which some think are a basis for learning new skills.
So the right parietal lobe contributes too.
It seems so, particularly for integrating visual input, although the left IPL seems more dominant for the action imagery itself. And we can't forget the subcortical structures, the basal ganglia and the thalamus. They're part of loops that modulate this whole motor planning process.
So it's really a distributed network, not just one or two spots.
Precisely. Newer models really talk about networks. There's the Praxis representation network involving left parieto-frontotemporal areas. And this idea of two streams is important too.
The ventral and dorsal streams.
Yeah. The ventral stream, the what pathway, is more about semantic knowledge understanding tool function. The dorsal stream, the where pathway, handles the spatiotemporal details, the precise execution in space and time.
So problems in the ventral stream might affect knowing what tool to use or how it works conceptually.
It's exactly affecting action semantics. While dorsal stream issues would lead more to those spatial or timing errors in actually doing the movement, specific areas like the left supramarginal gyrus and parts of the temporal lobe seem key for linking concepts to motor plans.
Fascinating.
And what's really interesting is the overlap between this praxis network and the mirror neuron system, the system involved in understanding and imitating others' actions.
So performing an action and understanding one might be linked.
It strongly suggests that. Lesions in different parts of this overlapping network seem to affect either gesture comprehension or gesture imitation. It hints at a deep connection.
Okay, this network view really helps. Now let's connect this back to the different types of limb apraxia. The source mentions 7 major ones, based on Hammond's work.
Yes, Hammond's classification is really useful. It looks at a patient's ability to imitate gestures, recognize them, perform sequences, and their fine motor skills. The pattern of deficits plus the types of errors they make, production errors versus content errors, helps sort them into subtypes and often points towards the lesion location.
Let's start with ideomotor apraxia. The source mentions 2 variants, parietal and disconnection. What's the difference?
Right. The parietal variant is often seen as the classic type. It's thought to stem from damage to the stored movement formulas, the praxicons, mainly in the left inferior parietal lobule.
So the blueprint itself is damaged.
Exactly. Patients struggle to perform skilled movements on command and when imitating. And crucially, they also have trouble recognizing gestures others make. Their movements often show errors in space, wrong hand shape, wrong path, and time jerky. Too fast, too slow.
Because the core representation is faulty.
Right.
Okay, what about the disconnection variant?
Here, the idea is the movement formulas in the parietal lobe are actually okay. The problem is a break in the connection between the parietal area and the motor areas in the frontal lobe, like the SMA or the pathways linking them.
So the blueprint is fine, but it can't get transmitted properly.
Precisely. These patients also have trouble pantomiming to command and imitating, often with similar spatiotemporal errors. But, and this is key, they usually can still recognize gestures because the underlying formula is intact.
That's a critical difference.
It is. The lesions are along that pathway from the left IPL towards the motor cortices. And sometimes, if the lesion is in the right SMA, the apraxia might mainly affect the left arm. Shows how important those cross-hemisphere connections are.
Definitely highlights the network aspect.
Yeah.
What about dissociation apraxia? That sounds like a separation of some kind?
It is. It's a really interesting one where errors only happen when the movement is triggered by a specific type of input, usually verbal commands. So it's often called verbal dissociation apraxia.
So they can't do it when asked, but maybe they could copy it.
Exactly. The idea is a specific disconnection between language areas and the movement formulas. But since visual or tactile cues can still access those formulas, they might imitate, okay, or use a real object correctly. And the errors they make to verbal commands are often quite bizarre, just unrecognizable movements, rather than the spatial temporal errors you see in ideomotor. While verbal is most common, you can theoretically have visual or tactile dissociation too.
Fascinating. Like one pathway is blocked, but others are open. Next is ideational apraxia. Does this mean a problem with the idea of the action?
Sort of, but it's more specific. It's about sequencing. The person can't correctly order the steps needed to achieve a multi-step goal.
Like making tea, they know all the steps, but do them in the wrong order.
Perfect example. They might pour water before putting the tea bag in. Each individual step might be okay, but the overall plan, the sequence, is messed up. Another classic is preparing a letter, maybe stamping the paper before writing.
And where does this come from?
It's often associated with more diffuse brain issues like dementia or delirium or large left hemisphere lesions involving the frontal lobe and SMA. Importantly, it's a sequencing problem, not necessarily a problem understanding the tools themselves.
Okay, that distinction matters. Which brings us to conceptual apraxia. This sounds like it is about understanding the tools and concepts.
Exactly right. Conceptual apraxia involves errors in action semantics that knowledge about the action's content, tool function, tool-object relationships.
So like using a screwdriver as a hammer.
That's a classic content error, yes. Or maybe choosing the wrong tool for a task altogether. They might also struggle to name a tool based on its function or describe what a tool is used for.
Can this happen on its own without the movement execution problems of ideomotor apraxia?
Yes, it can. They can occur together, but conceptual apraxia can stand alone, suggesting the systems for understanding actions and executing them are at least partly separate.
Where do we typically see this?
It's common in Alzheimer's and other dementias, and with diffuse posterior brain lesions, particularly in the left hemisphere.
Okay, clear difference there. Ideational is sequence. Conceptual is the underlying knowledge. Now, kinetic apraxia. The source notes some debate about whether it's a true apraxia.
Yeah, the debate centers on,
How so?
well, it could present as a left-sided disconnection type ideomotor apraxia, can't pantomime with the left hand to command or imitation, but recognizes gestures. Or it could be a left-sided dissociative apraxia, trouble with verbal command for the left hand, but imitation and real tool use are better.
So different patterns depending on the causal lesion.
Yes, or even a combination. Lesions in the middle part might cause left limb kinetic and ideomotor apraxia.
And this is where we might see things like the alien limb.
Correct. Callous lesions are one cause of the alien limb phenomenon where the non-dominant hand seems to act on its own without conscious intent. And you can get diagnostic apraxia, where the two hands work against each other, one buttons while the other unbuttons.
Like in split brain patients.
Precisely. And very rarely, you might even see conceptual apraxia limited to the left hand after a callosal lesion, which is intriguing regarding how conceptual knowledge is represented across hemispheres.
Wow, these subtypes really illustrate the complexity. So how do clinicians actually test for all these different limb apraxias? It sounds like it requires a careful approach.
It absolutely does. First step is always ruling out those other issues, basic motor, sensory, general cognitive problems. Once that's clear, testing usually starts with pantomime to verbal command.
Asking the patient to show how they do something.
Right. Both transitive actions involving tool use, like combing hair, using scissors, brushing teeth, and intransitive ones, communicative gestures, like waving goodbye, hitchhiking, beckoning. You test each limb separately.
And what are you looking for?
You're watching closely for those spatiotemporal errors, incorrect hand posture, wrong movement path, jerky or poorly timed motion. And for content errors, doing the wrong action altogether, or maybe using a body part as the tool.
Using your finger as a toothbrush, for example.
Exactly. That's a classic error called body part as object, so you know the types of errors.
Okay, what if they struggle with pantomime to command?
Then the next step is usually imitation. The examiner performs gestures transitive, intransitive, and also, importantly, meaningless gestures.
Meaningless. Like what?
Things that don't represent anything specific, like touching your thumb to your pinky or making interlocking circles with fingers. Difficulty copying these meaningless gestures can point towards parietal lobe issues, maybe ideomotor apraxia, or problems processing the spatial aspects of movement.
Okay.
Trouble with bimanual meaningless gestures can sometimes suggest problems in both parietal lobes, like in Alzheimer's.
What else is assessed?
Gesture knowledge is important. The examiner performs gestures and asks the patient, "What am I doing?" Or, "Was that done correctly?" This helps separate production problems from understanding
Makes
problems.
sense.
Then sequential actions, asking the patient to demonstrate a multi-step task, like making that imaginary sandwich or preparing the letter. You watch the order of steps. If they struggle, you might try again with real objects to see if that helps.
Testing for that ideational apraxia component.
Right. And for conceptual knowledge, you might show them pictures or real tools and ask them to show how they're used or describe the function or give them a task context. You need to hammer this nail and ask them to pantomime the tool use.
And for limb kinetics specifically.
You'd include tests of fine finger dexterity, rapid finger tapping, touching thumb to each finger sequentially, picking up a small coin without sliding it, coin twirling.
Okay. And does using real objects often help?
It often does, yes. If apraxia is suspected, testing with real objects is a key step. Many patients improve when they have the actual tool in hand or make spontaneous gestures in context. The amount of improvement gives clues about severity and type.
And there are formal tests too, right? Standardized batteries.
Yes, several good ones exist, like the Apraxia battery for adults too, the Florida Apraxia battery. These provide standardized ways to score performance and can be very helpful in differentiating the subtypes based on the specific pattern of errors across tasks.
This detailed testing must give clues about the underlying brain areas involved too. Where are lesions typically found?
For ideomotor apraxia, as we touched on, it's very commonly associated with left hemisphere lesions, particularly the inferior parietal lobule, but also frontal areas like the premotor cortex and SMA.
And subcortical structures.
Yes, lesions in the basal ganglia, thalamus, or the white matter tracts connecting these areas, including the corpus callosum, can also cause it, basically damage to this network. Stroke is a very common cause, especially left MCA strokes. Right, ACA strokes can sometimes cause that disconnection type.
Okay.
And certain neurodegenerative diseases like corticobasal syndrome or the parietal variant of Alzheimer's, often present with ideomotor or limb kinetic apraxia.
What about handedness? Does being left-handed or right-handed make a difference?
That's a really interesting question. The classic view is that for right-handers, the left hemisphere is dominant for these movement formulas. Functional imaging mostly supports this, showing left IPL activation.
So left hemisphere lesion is more likely to cause apraxia in a right-hander.
Generally, yes. For left-handers, it might be more likely stored in the right hemisphere, so a right-sided lesion could potentially cause apraxia. But it's not perfectly clear-cut.
How so?
Well, you see some right-handers with large left lesions who don't get apraxia, and very rarely a right-hander might get apraxia from a right-sided lesion. So while the left hemisphere dominance is strong for most right-handers, there's definitely some individual variability.
It's never simple with the brain, is it? Given the impact on daily life, what about rehabilitation? What can be done?
Yeah, the functional impact is significant. Apraxia correlates with needing more help after stroke, difficulties returning to work. Unfortunately, there's no single cure or standard treatment that works for everyone. No specific medications are effective right now.
So it's mainly rehabilitation strategies.
Primarily, yes. Therapy often involves using multiple cues, verbal, visual, tactile, along with lots of repetition and feedback. Focusing on naturalistic functional activities is key. And starting therapy early after an acute event like stroke seems beneficial.
What about trying to teach general strategies?
Cognitive strategy training, teaching general problem-solving approaches has shown mixed results. It helps some people generalize skills to other tasks, but not everyone.
Any newer approaches being explored? Technology.
Yes, there's research into things like non-invasive brain stimulation, like TMS targeting parietal or motor areas, which shows some temporary improvement in some people.
Interesting.
Also, sensor-embedded tools for feedback, video game-based systems for training grasp, even virtual reality scenarios for practice.
Does the training stick? Can people generalize what they learn?
That's often the challenge. Patients can learn specific new gestures or improve existing ones with practice, but generalizing that improvement to untrained tasks or real-world situations can be difficult.
Yeah.
Still, studies do show gesture production exercises can lead to measurable gains that can last for a while.
So specialized therapy is important.
Absolutely. Referral to occupational or physical therapists with experience in apraxia is really crucial. And simple environmental changes can help too, removing unsafe tools, simplifying choices, breaking tasks down.
Before we switch gears to agnosia, the source mentions some related disorders that might look similar or co-occur.
Yes, good point. We mentioned the alien limb phenomenon already. Then there are issues with movement initiation, akinesia, can't start, and hypokinesia, slow to start, often seen in Parkinson's or with frontal lobe issues.
Yeah.
Frontal lobe problems can also cause things like motor impersistence, can't sustain a posture, primitive reflexes like grasping, echopraxia, imitating others involuntarily, utilization behavior, inappropriately using objects just because they're there.
Right, that environmental dependency.
Exactly. Also, catalepsy or waxy flexibility and motor perseveration, getting stuck repeating a movement. Lots of ways motor control can go awry beyond apraxia itself.
A complex landscape indeed.
Yeah.
Okay, let's transition now. Shifting focus to Chapter 12 and the world of Agnosia's problems with recognition. What's the basic definition here?
Agnosia fundamentally is a failure of recognition despite intact primary sensation. Freud originally used the term. The key idea, maybe best put by Milner and Tuber, is it's like a normal percept stripped of its meaning.
So you can see it, or hear it, or feel it perfectly well.
Right, you can perceive the sensory features, the shape, the color, the sound, the texture, but you just can't identify what it is. The sensory input gets in, but the brain can't make sense of it.
What are the diagnostic criteria? How do you pin it down?
Okay, several things need to line up. One, clearly a failure to recognize something in a specific sensory modality. Two, perception in that modality has to be basically normal. It's not just bad eyesight or hearing loss causing the problem.
Got it.
Three, and this is crucial, they can usually identify it if they use a different sense. So someone with visual agnosia might not recognize a key by sight, but knows it instantly by touch. This helps rule out a general naming problem like anomia.
Okay, modality-specific failure.
Exactly. And fourth, it shouldn't be due to generalized dementia or confusion. While recognition fails in dementia, true agnosia is more specific. It usually affects just one modality, though it can be selective within modality too, like only affecting face recognition, prosopagnosia, or color recognition, color agnosia.
So diagnosis requires careful exclusion of sensory and general cognitive issues.
Absolutely. You have to rule out primary sensory loss and things like aphasia or dementia, where naming problems aren't usually tied to just one sense.
Why is understanding agnosia so important? What does it tell us?
Well, clinically, it helps make sense of some really unusual patient presentations. But beyond that, agnosias offer incredible insights into how the brain actually builds our perception and recognition of the world. They often involve damage to association cortices, where sensory information gets integrated and processed.
And they can result from various causes.
Yes, often bilateral or diffuse damage from lack of oxygen, multiple strokes, head injuries, and they're also important features in neurodegenerative diseases. There was historical debate about whether they were real or just part of general decline, but case studies strongly support true specific agnosic deficits exist.
How is the source structuring this section?
It logically goes by sensory modality, visual first, then auditory, then tactile. And within each, it kind of moves from more basic sensory dysfunction up to the higher level recognition disorders, the agnosias themselves.
Okay, let's start with vision then. The source begins with cortical visual disturbances. How do these relate to recognition?
Right, so damage to the occipital lobes, the brain's visual centers, causes these. Bilateral damage can lead to cortical blindness. Some people with this have Anton syndrome. They're unaware they're blind, might even confabulate what they see. It's like the thinking parts of the brain don't know there's no visual input.
That's bizarre.
It is. Then there's the opposite, almost blind sight, where someone is cortically blind but can still react behaviorally to visual things they don't consciously see, maybe mediated by subcortical pathways. Some view this as a kind of agnosia, a failure to recognize what's being processed at some level.
Like catching a ball without seeing it.
Exactly that kind of thing. Cortical visual loss can also cause hallucinations from simple lines or spots to complex formed images, like in Bonnet syndrome, often linked to hyperexcitable visual cortex. Oliver Sacks wrote beautifully about these.
And diagnosing cortical blindness involves?
Checking for no eye problems, preserved pupil reflexes, and often associated neurological signs like confusion or memory loss, especially if posterior cerebral artery strokes are involved. It can be transient, too, after head injury, migraines, seizures, and it can develop in various conditions like PRES, meningitis, lupus, and certain dementias like Heidenhain CJD variant or posterior cortical atrophy.
What about cortical visual distortions? Are those agnosias?
No, these are seen as problems with perception itself, not recognition. Things like metamorphopsia, distorted shapes, scintillating scotomas, flickering spots, techopsia, zigzags and migraines, seeing things too big or too small, micropsia, macropsia.
Alice in Wonderland syndrome.
Right. Loss of color vision, achromatopsia, motion perception, achinotopsia, seeing images persist, palinopsia, seeing multiple images, polyopia. These are distorted percepts.
Okay. But color issues can relate to agnosia.
Yes, achromatopsia is loss of color vision from occipital damage, but color agnosia is different, often seen with pure alexia after a left occipital lesion. The person can match colors okay but can't name them visually. They might confabulate names. It's a recognition deficit for the perceived color.
Got it. Now, balance syndrome and simultaneous agnosia sound quite complex.
They are. Balance syndrome is rare, usually from bilateral parietal frontal lesions. It's a striking triad. 1, difficulty voluntarily shifting gaze, ocular motor apraxia. 2, trouble reaching accurately under visual guidance, optic ataxia. And 3, severely narrowed visual attention, only seeing one thing at a time.
Can't see the forest for the trees.
Literally, they might only see one tree. Testing often involves interpreting complex pictures, like the cookie theft scene. You can also get partial balance, like isolated optic ataxia, which is a dorsal stream issue.
And simultaneous agnosia.
That's a core attention problem from balance inability to see more than one thing at once, seeing details but not the whole scene, often linked to left occipital lesions and that letter-by-letter reading type of pure alexia. Some research suggests a problem with spatial organization might underlie it. And like balance, you can see it in posterior cortical atrophy.
Okay, that leads us to visual object agnosia itself. The source highlights Lissauer's distinction. Apperceptive versus associative. What's the core difference?
It's fundamental. Apperceptive agnosia is a problem forming the visual percept. They can see basic features, lines, colors, but can't put them together into a coherent whole object. It's hard to fully separate from a basic perception problem. They struggle with objects seen from odd angles or telling similar objects apart.
Luria's example of eyeglasses seen as a bicycle.
Classic example, yes. Focusing on parts, not the whole shape. Often linked to bilateral occipital lesions, maybe during recovery from cortical blindness, right? Parietal cortex seems important here too.
Okay, and associative agnosia.
Here, the perception is thought to be relatively intact. They can often copy drawings of objects they can't recognize. The problem is linking that intact percept to its meaning or identity.
So they see it fine but don't know what it is.
Exactly. But crucially, they can recognize it through touch or sound. This rules out a general knowledge or naming problem. It's often linked to bilateral posterior lesions, involving areas like the fusiform gyrus, often with color agnosia or prosopagnosia too.
Geschwind suggested a disconnection from language areas.
That was his idea, yeah.
Yeah.
Visual info can't reach left hemisphere language areas. Probably too simple, but the disconnection idea is relevant. Modern views focus more on that ventral what stream disruption for object recognition. Rehab often involves compensatory strategies using other senses.
Where does optic aphasia fit in? It sounded like a mix.
It is. It's between agnosia and aphasia. They can't name a visually presented object, but they can show they recognize it by pantomiming its use or describing its function.
Ah, so recognition is intact, unlike associative agnosia.
Correct. And they can name it via touch or sound, unlike anomic aphasia. So it seems the visual info gets recognized somewhere, maybe right hemisphere, but can't connect to the left hemisphere naming centers. Another kind of disconnection, they might confabulate names too, often seen with alexia without agraphia and color agnosia, suggesting left occipital lesions.
Makes sense. Now, prosopagnosia, inability to recognize faces. A very specific visual agnosia.
Very specific, yes. Failure to recognize familiar faces, friends, family, even oneself, relying instead on voice, gait, hair, clothes. It's usually limited to visual modality and faces specifically.
And it has apperceptive and associative forms too.
It does. Apperceptive is trouble processing face features, difficulty matching faces. Associative is being able to match faces but not recognizing familiar ones. There's debate about whether faces are special perceptually, but evidence suggests dedicated brain areas.
Where are these areas?
Like other visual agnosias, often bilateral temporo-occipital regions, fusiform gyrus especially, the fusiform face area, or FFA, occipital face area, OFA, anterior temporal regions. Seems to be a network, predominantly right-sided. Disconnection from face memory stores is also proposed. It occurs after stroke injury, but also in dementias like FTD or posterior cortical atrophy. Rehab strategies are being explored.
And recognizing emotion in faces, is that related?
Often involves the right hemisphere too. Damage disconnecting visual areas from emotion-related regions might cause agnosia specifically for facial expressions.
Lastly, for visual, Kluver-Bucy syndrome. That sounded quite severe.
It is. First seen in monkeys with bilateral temporal lobes removed. In humans, similar damage from herpes encephalitis, surgery, Pick's disease, causes a constellation of symptoms.
What kind of symptom?
Visual agnosia, prosopagnosia, memory loss, placidity or apathy, altered sexual behavior, often hypersexuality, excessive eating or mouthing objects, hyperorality. It's thought to result from disconnecting visual input from the limbic system. Vision loses its emotional meaning and associations. Humans usually show partial syndromes mixed with other deficits like aphasia.
A profound disconnection.
Yeah.
Okay, let's move to auditory agnosias, problems recognizing sounds.
Right. This ranges from cortical deafness, inability to process sound at the brain level, to specific recognition deficits. Usually requires bilateral temporal lobe damage affecting the primary auditory cortex in Heschel's gyri. Unilateral damage often has little effect.
So bilateral damage is key.
Typically, yes. Complete cortical deafness is rare. Usually some basic tone hearing remains, but higher level processing, identifying sounds, sequencing, localization is impaired. These deficits blend into auditory agnosias.
Or they hear a noise but don't know what it means.
Exactly. Can't recognize animal sounds, bells, etc. Often includes trouble understanding speech or music, too. Subtypes include pure word deafness, auditory nonverbal agnosia, phone agnosia, voice recognition, and amusia, music. Patients might have one or a mix.
Let's start with pure word deafness.
This is specifically inability to comprehend spoken words, while hearing nonverbal sounds is okay, and speech production is usually fine. Often evolves from cortical deafness. Classic explanation is disconnecting both auditory cortices from Wernicke's area, left hemisphere language comprehension. Unilateral left lesions can also cause it, maybe strategically placed. It can look like severe Wernicke's aphasia, and often patients do have paraphasic speech errors, linking it closely.
And auditory nonverbal agnosia.
That's the flip side almost. Lost ability to identify meaningful nonverbal sounds, dog bark, phone ring, but language comprehension and pure tone hearing are okay. Usually bilateral temporal lesions, though a unilateral left case has been reported.
Then phone agnosia, like prosopagnosia, but for voices.
Exactly. Failure to recognize familiar people by their voice can be apperceptive, trouble matching unfamiliar voices, temporal damage, or associative. Can't recognize familiar voices, linked more to right parietal. Right anterior temporal lesions seem important, sometimes linked with face recognition deficits too, multimodal.
And related is auditory affective agnosia.
Yes, inability to recognize emotional tone in speech, usually right hemisphere lesions. Progressive phonagnosia can occur in FTD. There was even a case of a bird expert with dementia losing bird call recognition specifically.
Wow. Finally, a music processing problem.
Right. Complex because music is complex. Can affect melody, rhythm, timbre recognition. Traditional view was right temporal for melody tone, left for pitch rhythm tempo. Newer work suggests left hemisphere is important for temporal sequencing in music and speech. Trained musicians show more left hemisphere activity listening to music.
So it varies.
It does. Ravel famously lost the ability to read-write music with his aphasia, but could still appreciate it. Progressive musical decline happens in dementia. One case lost perception of happy, sad music after right temporoparietal surgery, but kept meter beat perception. Highly specific deficits are possible.
Fascinating complexity. Okay, last category. Tactile agnosias. Recognizing by touch.
Right. These involve parietal lobe lesions despite intact primary sensation,
Yeah.
touch, pain, temperature, vibration, position sense. Common forms are asterognosis, can't identify objects by touch with the opposite hand.
Agraphesthesia.
Can't recognize numbers, letters traced on the skin, again, usually contralateral side. Both are higher-order tactile processing deficits. Associative tactile agnosia is being able to describe features, shape, texture, but not identify the object by touch alone, though they can by sight sound.
What did Casilli's work show?
Confirmed it can happen without primary sensory loss. Neglect, often from right hemisphere lesions, made it worse. Bilateral deficits were mainly seen with neglect. Left parietal lesions caused right-hand tactile agnosia. Suggests bilateral lesions likely cause more profound tactile agnosia, like in vision hearing.
What are the mechanisms thought to be?
Involves sensory cortex for shape texture analysis. Maybe right hemisphere more apperceptive, left more associative. Right parietal's spatial role contributes. Attentional deficits, neglect from right hemisphere worsen it. And disconnection, like Deschman's callosal patient, unable to name object in left hand but could point, suggesting right parietal disconnected from left language areas.
Is there a tactile aphasia too?
Yes, analogous to optic auditory aphasia. Can't name a palpated object despite recognizing it by touch and being able to name it via other senses. It's considered quite rare, though.
So across the board, Agnosias really show recognition is way more than just raw sensation.
Absolutely. It requires that primary sensation, plus associating it with past experiences, memories, meaning. It's the association cortices integrating everything. Agnosias give us this amazing window into how that complex process works and how it can break down.
This has been a really comprehensive deep dive into limb apraxias and agnosias. Just to recap the big picture, apraxia is about the doing, the motor programming with different types like ideomotor, ideational, limb kinetic, linked to specific brain networks and error patterns.
Right. And agnosia is about the recognizing across different senses, visual, auditory, tactile, with key distinctions like apperceptive versus associative, and specific forms like prosopagnosia or amusia, highlighting how specialized brain functions can be.
Both are clinically really important for diagnosis and understanding the challenges people face with neurological conditions.
Definitely. And while treatments, especially for apraxia, are still evolving, and management for agnosia often relies on compensation, ongoing research keeps improving our understanding and hopefully will lead to better interventions.
It really makes you think, doesn't it?
Yeah.
Considering how intricately our brains handle moving and recognizing, what other subtle ways might brain disruptions affect our everyday interactions? Things we might easily overlook. How can we become more attuned to these signs?
That's a great question to ponder. There's so much subtle complexity in how we navigate the world.
Definitely food for thought. If you want to explore this more, we really recommend checking out the source material or related research. Thanks for joining us on the Deep Dive.